All right, we're going to get into staging of pressure injuries. As you can see, I've been saying pressure injuries. Just about a week and a half ago, the National Pressure Ulcer Advisory Panel got together in Chicago. About 400 individuals voted on new definitions, and they did get rid of the word pressure ulcer and replaced it with injury. The reason being is that ulcer describes an open wound, and staging not necessarily describes only open. It describes intact and open, so that's why they said injury. They did get rid of suspected deep tissue or suspected from deep tissue injury, and it's now deep tissue pressure injury. So we'll be going over some of these new definitions as well. Yeah, that was just about a week and a half ago. So the staging system, this is only used for pressure wounds. You will not use this for any other type of wound, so only pressure. And it's a good practice to be, when you're declaring a pressure wound, to have another, maybe another nurse, another set of eyes in there with you to declare it. So you have stage 1, 2, 3, 4, unstageable and deep tissue pressure injury. So the new definition for pressure injuries. A pressure injury is localized damage to the skin and or underlying soft tissue, usually over a bony prominence or related to a medical or other device. The injury can present as intact skin or an open ulcer and may be painful. The injury occurs as a result of intense and or prolonged pressure or pressure in combination with shear. This tolerance of soft tissue for pressure and shear may also be affected by microclimate, nutrition, perfusion, comorbidities, and condition of the soft tissue. I also want to share, according to the Agency for Healthcare Research and Quality, over 2.5 million people in the United States develop pressure injuries every year. Pressure injuries cause pain, risk for infection, and increased healthcare needs. And the Centers for Medicare and Medicaid do not provide reimbursement to hospitals who acquire pressure injury while at the hospital. So this is why prevention is crucial in acute care hospitals. So this is also important to examine your patient very thoroughly, especially on admission. Patients that are at risk for pressure injuries include the elderly, incontinent, bed or wheelchair-bound patients, or spinal cord injury patients are some examples. The most common pressure injury sites are the sacrum and then the heels. So what factors influence the development of pressure injuries? The intensity of the pressure, the amount of weight distributed to the area, length of time or the duration, the patient's ability to tolerate the external pressure, and the shearing force, friction, and excessive moisture can also contribute. So before we get into the stages, I do like to go over layers of the skin in order to understand the staging. So keep these in mind when you go over staging. So you have the epidermis, then you have the dermis, then directly below is the adipose tissue, and then the muscle, and then the bone. So stage 1 pressure injuries. This involves intact skin, non-blanchable erythema, usually over a bony prominence. And this involves the epidermis. Stage 1 can be difficult to detect in darker skin tones and may not have visible blanching. So you want to look for changes in sensation like pain or temperature. Is it warm or cool? Or the firmness. Is it firm or soft compared to the adjacent skin? Sometimes you can, according to national guidelines, you can moisten the skin to assist with visual changes as well, and to assist with observing the skin changes. The patient's skin may feel firm or soft before seeing visual changes, or maybe sometimes they have some pain to an area, and you may indicate a stage 1 pressure injury. So you do not want to confuse this with deep tissue pressure injuries, where those are more maroon, dark purple discoloration. Now, stage 1 pressure injuries, according to the University of Washington Medical Center, if there is redness to the skin and fades after 15 minutes, then no damage occurred to the skin. So if before declaring maybe a stage 1 pressure injury, maybe reposition the patient, wait 15 minutes, and then go back and see if the redness persists. Stage 2 pressure injuries. This is partial thickness skin loss. You're into the dermal layer of the tissue. So this wound bed is 100% pink, 100% red. You will not see yellow tissue or the adipose tissue in this area or in this stage. This involves also an intact serous blister because you're into the dermal layer, or a ruptured serous blister. So it does not involve the adipose fat, tissue, slough, eschar, or granulation tissue in this stage. So you won't see the yellow tissue. Stage 2 injuries commonly result from adverse microclimate and shear in the skin over the pelvis and shear in the heel. So that was a new definition recently. So also do not stage or confuse other wounds with stage 2, such as traumatic wounds. So skin tears, burns, or abrasions, you don't want to stage those or confuse them. Also, don't confuse them with moisture-associated skin damage, including incontinence-associated dermatitis, which we'll go over in a little bit as well. And also don't confuse it with intertriginous dermatitis. Intertriginous dermatitis is inflammation of the skin. This is when skin folds cause rubbing or friction against one another, and it's created from friction and moisture rather than causing pressure. So make sure, is it really just moisture related from the folds, or is it pressure related? Medical adhesive related skin injuries, make sure you don't confuse this with stage 2 as well. Make sure you ensure you know what the cause is before declaring it. Investigate. Stage 3 pressure injuries are full thickness skin loss involving adipose tissue. But bone, muscle, tendon, fascia, ligament, or cartilage are not exposed or palpable in this stage. Granulation tissue and epibole or rolled edges are often present. Slough or eschar may be present but does not obscure the depth of the wound bed. If you cannot see the depth of the wound bed, then it would be unstageable. Undermining and tunneling can occur as well. So stage 3 pressure injuries can be shallow depending on the anatomical location. So the bridge of the nose, the ears, the malleolus, the occiput, the back of the head, those can be shallow. Or you can have deep stage 3 pressure injuries due to areas of high adipose concentration. Stage 4 pressure injuries. This involves full thickness skin and tissue loss, which entails exposure of bone, tendon, muscle, ligaments, or cartilage. Slough or eschar can be present. Epibole or rolled edges often occur. Undermining and tunneling are frequently present. And once again, depth varies depending on the anatomical location. So stage 4 can even be shallow depending on the location, the nose, back of the head, and so forth. So I keep talking about epibole with stage 3 and 4 pressure injuries. So epibole are the rolled edges that you do not see in stage 2 pressure injuries. So a lot of times with these wounds, if I can sometimes stall the wound to a certain extent. So sometimes even with a wound vac, I have to try to break up those edges in order for those epithelial cells to be exposed to help close that wound when it becomes more superficial. Unstageable pressure injuries involve obscured full thickness skin and tissue loss, but the extent of damage is unknown. So it's obscured by slough, that yellow, tan, gray devitalized tissue, or eschar that's tan, brown, or black. So the stage is not known, but it will be either a stage 3 or 4 pressure injury once it's exposed. So a lot of times I describe this as you don't want to stage it. If you're thinking, well, maybe once that slough is removed, I don't know, maybe there is bone exposed once that tissue is removed, but I can't stage it until I know that's removed and various layers are exposed. So it would be a 3 or 4 when you are comfortable staging it. So once that slough is removed. But once again, eschar on the heels, those are unstageable, but they should not be removed if it's stable eschar. Unless there's erythema or purulence, or if it's on an ischemic limb, it should not be removed if it's stable, though, since the body's natural Band-Aid. Deep tissue pressure injury, the new definition, intact or non-intact skin with localized area of persistent non-blanchable, deep red, maroon, purple discoloration, or epidermal separation, revealing a dark wound bed or blood-filled blister. This injury results from intense and/or prolonged pressure and shear forces at the bone-muscle interface. So damage is done deep below, and so that's where you get like blood vessels are broken, you get the weeping of the blood into the surrounding tissues, and that's how you get that dark discoloration with deep tissue pressure injuries. And once again, it can be difficult to detect in darkly pigmented skin, so you want to look and see, do they have pain, do they have any temperature changes that often precede skin color changes. And the affected area may be painful, warm, or cool compared to the surrounding tissue. So the depth is unknown. So a lot of times I like to say it needs to present itself. Sometimes I need to tell families when a patient comes to me with a horrific deep tissue pressure injury, I need to explain to them this might get worse before it gets better. It may eventually expose various layers of the tissue over time despite optimal treatment because the damage was already done. The deep tissue pressure injury can be eventually covered with eschar to make it an unstageable pressure injury. Or even deep tissue pressure injuries can also resolve without tissue loss as well. Many deep tissue injuries have resolved on their own. If necrotic tissue, subcutaneous tissue, granulation tissue, fascia or muscle, or other structures are visible, then this indicates a full thickness tissue loss or full thickness pressure injury, and is therefore a stage 3, 4, or an unstageable if covered with eschar or SLEP. You do not want to confuse these deep pressure injuries with vascular, traumatic, neuropathic, or dermatological conditions. I do want to make note too with staging, you do not do reverse staging. So if you have a stage 3 pressure injury, it's always a stage 3 pressure injury. You do not backstage. So if it is healing, you wouldn't say now it's a stage 2 pressure injury. You would simply say it's a healing stage 3 pressure injury. However, it can get worse and become a stage 4. The reasons being with that is as it fills in with granulation tissue, you can no longer see the various layers of tissue in order to stage it. And also that can affect reimbursement as well. Pressure point assessment. You want to make sure you're performing a head-to-toe skin assessment daily or according to your facility's policy. Look for any signs of pressure injury. So pressure points that you want to look at is the sacrum or coccyx, ischium, trochanters, heels, elbows, occiput, and beneath medical devices. All right, so after staging, let's review. What makes this a stage 1 pressure injury? Anyone? Intact, red, non-blanchable. Into the epidermis. What makes this a stage 2? What's that? Anyone? It's open red. You're into what layer? Dermis. Okay. What about the surrounding skin? It's kind of hard to tell in this picture. There's some maceration around it. This picture is also showing in combination with incontinence-associated dermatitis as well. So you can have a combination of 2 different causes as well, and that's going to make them more prone to breaking down with pressure as well. Okay, stage 3. What makes this a stage 3? Slough. What else? Rolled edges. Pibbly. Yeah. You're in the subcutaneous layer. The shallow. Yes. Slough. What makes this a stage 4? And this might be something that you need to palpate when you're assessing to see if you can feel bone. Tunneling. Yeah, you could use a Q-tip to gently probe, not shove, but. What else? So, undermining, tunneling, bone. Okay. You can always look into the history too. Make sure you're looking into the chart, maybe the surgical op report. A lot of times a doctor will discuss that they had to remove part of the bone, the osteomyelitis. Okay. What makes these unstageable? To heal on the left and the vertebrae on the right. Eschar, and the slough is covering, so it's obscuring the depth of the wound bed. Okay. Would you want to remove it on the heel on the left side? Stable. Okay. But yeah. palpate. What stages could these be? 3 or 4 eventually, yeah. And the vertebrae, that might be something you would palpate, see if it's warm. If there's induration, you might want to call the doctor. This looks infected. Deep tissue pressure injury, what makes this deep tissue injury? Purple, maroon, yeah. And this is to, it may be blanchable in between those, you can see on the right and left, so this is where you want to differentiate the two wounds, right sacrum or right gluteal or left sacrum, and measure those two different deep tissue injuries. And also, let's say if it's on a different part of the body too, you want to make sure you look into, did they fall on their hip? Is it more trauma related rather than pressure? Okay, medical device skin assessments. You want to inspect under and around a medical device at least twice a day. That's according to national guidelines. For any sign of injury, you want to catch early. So if you start seeing rubbing or any redness, you want to make sure you're patting that area appropriately. Maybe it's something, it's a device that you can maybe DC temporarily, or maybe you need to call physical therapy to reevaluate the fitting of the brace if you're seeing some early signs of breakdown. Localized or generalized edema. You want to assess greater than twice a day because fluid shifts can cause the medical device that once fit properly now to cause pressure on the skin, making the patient more vulnerable to pressure injury. So like I said, with a brace, maybe it needs to be readjusted because it doesn't fit properly anymore due to the edema. So you can ask PT to come and look at it, and you want to get the underlying cause treated. Following you also want to follow your manufacturer guidelines for your devices as well for proper fitting. We'll talk more about that too later. Mucosal membrane pressure injuries. So the new definition is found on mucous membranes with a history of a medical device in use at the location of the injury. So this involves the mucous membrane. This is the moist lining that communicates to the exterior, such as the tongue, the GI tract, nasal passages, urinary tract, and the vaginal canal. So these tissues are vulnerable to pressure from medical devices. They can create pressure, so oxygen tubing, ET tubes, bite blocks, orogastric or NG tubes. Urinary catheters can cause a mucosal pressure injury to the urethra. Fecal management systems can cause a pressure injury or a mucosal pressure injury to the anal sphincter or to the rectum. The staging system is not used due to the anatomy of this tissue because muscle is seldom seen and bone is not present. And non-blanchable erythema cannot be seen in the mucous membranes. So, and you also cannot distinguish partial versus full thickness tissue loss with mucosal tissues. So the tissue layers cannot be deciphered, therefore they cannot be staged. So simply you would just label it as a mucosal membrane pressure injury. You would not stage mucosal injuries. All right, friction and shear. So friction is two forces rubbing against one another, causing damage of the tissue layers. So this occurs with patients lying down in bed. So these are not necessarily considered pressure injuries. So moisture can play a role and can increase friction due to the patient sticking to the surface. For examples, friction can cause serious blisters because you're into the dermis layer. And you want to use dressings also to prevent friction as well. Shear. So shear can goes hand in hand a lot of times with pressure. This contributes to the pressure damage. So the skeleton of the body is pulled down or stays stationary while the skin slides down to the bed or chair, or when they're dragged up in bed. So this causes separation of the tissue layers, and shearing disrupts the blood supply. Deep tissue pressure injury versus a bruise. So the purple skin is presented around 48 hours following pressure injury. And the extent of damage is not known, and no known depth and extent of damage is not known with the deep tissue injury, as we have talked about, because it can be instageable or become a 3 or 4 or resolve on its own. So according to the national guidelines, the reasons for the rapid deterioration seen with deep tissue pressure injuries may be a combination of the direct ischemic injury and reperfusion injury from oxygen-free radicals, cytokines, and neutrophilic adhesion to the microvascular endothelium. Now bruises. This is extravasation of the blood into the surrounding tissues. A lot of times with bruising, I do see that yellow-green color around the bruising where I don't see it with deep tissue injuries normally. So this results from the blunt force, or this is from trauma. So this is more trauma-related. And this approximately takes about 2 weeks for healing.
Renee, will a bruise blanch?
Will a bruise blanch?
Yeah.
In my experience, I haven't been able to have it blanch. And there wasn't much. I was looking on research too of deep tissue injuries versus bruising. There's nothing. There's no, yeah, there's slim pickings on that. There needs to be more research on it. Why is it imperative to stage and measure pressure injuries? So you need accurate coding of pressure injuries, whether it be hospital acquired or admission or discharge for correct reimbursement. So the Centers for Medicare and Medicaid evaluates the measurements and staging for pressure injuries on admission, discharge, and on acquired. So for example, on admission, like I said, make sure you do a thorough skin assessment. If it's missed on admission, then later on it's discovered if you have to acquire it. So the facility is at risk to not receive payment and will be treated as an acquired pressure injury, and this can affect your benchmark compared to other facilities. Also, it's important to document prior to discharge. For example, I had a patient that I saw about 15 minutes before they left, did a head to toe. We take pictures where I'm at too, and they left about 2 weeks later, 2 to 3 weeks later. The receiving facility called and said that we caused the pressure injury. However, we had all the documentation and said they left with nothing at our facility, and all the questioning stopped right there. So that's why your documentation is very, very important. Incontinence-associated dermatitis, also known as perineal dermatitis. This results from inflammation, erosion, and this is exposure from urine or stool. So urine or stool can change the pH of the skin, making the skin at risk to break down. For incontinence-associated dermatitis, you want to use a breathable pad with these patients because you want to use the beneficial part of the air beds with these patients with IAD. You don't want to defeat the purpose of the bed and you want to help control the moisture and heat from the skin. And also make sure and educate your CNAs to use one pad, not multiple pads. Once again, that will defeat the purpose of the airflow of the bed. Incontinence-associated dermatitis. So I want to share this more research. In 2009, a group of clinicians reviewed research on incontinence-associated dermatitis. Their literature review identified supporting research in regarding to proper skin care for IAD. So these include gentle perineal cleansing, moisturization, and application of a skin protectant. Clinical experience also supports application of an antifungal powder, ointment, or cream in patients with evidence of cutaneous candidiasis. Aggressive containment of urinary or fecal incontinence, and a highly selective use of a mild topical anti-inflammatory product in selected cases. So further research needs to be determined for proper treatment and prevention of IAD. So I want to share this too because yeast is commonly seen with IAD, so a lot of times you do need an antifungal to help treat that, the redness. What you see is the satellite lesions, the dotted redness, that's the yeast spreading. So that's why you need to a lot of times use an antifungal with these cases as well. All right, arterial ulcers. So I want you to be able to differentiate other different types of wounds. So these are normally found on the tips of the toes. They have spontaneous necrosis due to the lack of blood supply. Areas of trauma on the feet due to the lack of blood supply. It's seen on the lateral foot, lateral heel. The wound bed can be pale, it can be necrotic, it can be painful and cool to touch due to the lack of blood supply. It's associated with ischemia, diminished or absent pulses, thin, fragile skin, They can have the elevational pallor and dependent rubor. So our management of arterial ulcers. So surgical procedures may be necessary to increase perfusion. So bypass grafts are most commonly constructed using the saphenous veins, angioplasty to open up the arteries, amputation would be the last resort for irreversible ischemia and invasive infection. So that's why it's crucial to palpate to see whether it's stable or not, or if they have purulent drainage. Medication. Medication to reduce the risk of thrombotic events, anticoagulants, and antiplatelet agents can be used. So risk factors include cardiovascular disease, hyperlipidemia, tobacco use, diabetes, and hypertension. Venous ulcers. This is in the lower extremities, usually between the ankles and the knees. You see this a lot of times on the malleolus, and that's due to a vein there that weakens, the valve weakens, and creates that hemosiderin staining, the red blood cells that weep into the surrounding tissues, get the hemosiderin staining. They are edematous that require compression, and a lot of times they have good pulses and are warm to touch as opposed to their arterial ulcers. So venous ulcers, treatment, compression therapy. Examples, elastic wraps, compression stockings, or Uniboot. And these compression therapies can assist with facilitating the normal venous flow. And many individuals may require long-term compression to prevent reoccurrence of these venous ulcers. Limb elevation is crucial as well to improve venous insufficiency, to return the blood flow by the use of gravity. And patients need to be taught to elevate their legs above their heart and to avoid prolonged sitting or standing with the legs in the dependent position. So they need to get up and walk to facilitate the blood flow and to prevent swelling. Surgical procedures include for recurrent ulcers and severe lipodermosclerosis, which is inflammation of the subcutaneous tissue. They get that champagne bottle look to their leg, and that's due to the valvular incompetence. Other therapies include physical therapy and exercise to improve calf muscle function to facilitate blood flow. Risk factors, DVT, leg trauma, venous disease or family history, thrombophilia, pregnancies, obesity, varicose veins, IV drug use of the affected extremity, arthritis affecting the calf muscle function, sedentary lifestyle, and prolonged standing. Okay, diabetic or neuropathic ulcers, a lot of times they're seen on the plantar surface of the foot, over metatarsal heads of the toes and the side of the feet. They're associated with callus formation. A lot of times that callus needs to be debrided multiple times in order for it to be healed. Infection can be common, but signs or symptoms may not be evident due to the high blood glucose level. Okay, so management is important with diabetic and neuropathic ulcers to prevent these ulcers because they're at risk for ulceration and amputation. Daily foot exams are crucial for the prevention of these ulcers and prevention due to the loss of protective sensation. So we must educate diabetic patients to inspect their feet for any cuts or redness, as well as if they have any cracks in their feet. They need moisturizer after bathing or not between the toes. After bathing, they need to dry between the toes and test the water temperature with their hands rather than their feet so they're not burning themselves. Do not soak the feet because this can cause maceration and it actually dries them out, taking the natural oils out of their skin. Proper nail care is important as well, and grown toenails should be seen by a podiatrist. But if they can file down their calluses with a pumice stone, maybe after a bath when it becomes more soft. But they should never use a razor blade to trim calluses or corns. Properly fitted shoes, you can advise them to use running or walking shoes, but to get these shoes later in the day when the feet are the largest. Inspect shoes before putting them on for any foreign objects. They should not use a heating pad or hot water bottles to warm their feet because they can burn themselves. And they also shouldn't advise them to not walk barefoot because this can due to their decreased sensation. Risk factors, diabetes, spinal cord injury patients.